Thank you for inviting me to be here today. So my name is Jonathan. I'm a palliative care pharmacist working in the northeast of England, and today we're going to run through end-stage and palliative stage Parkinson's disease, particularly with a focus on the use of pharmaceutical agents for the management of motor and non-motor symptoms. Now, this is the classification of Parkinsonism according to the American Association of Neurology, and they break down Parkinsonism as secondary to one of three causes. It can be due, in the majority of cases, to idiopathic Parkinson's disease. It can also be due to identifiable causes such as drugs, vascular damage, or it could be due to other neurodegenerative disorders such as atypical forms of Parkinson's disease, particularly things like progressive supranuclear palsy and corticobasal degeneration. For the purposes of today, however, we're going to purely focus on idiopathic Parkinson's disease. Now, as I'm sure you're all aware, idiopathic Parkinson's disease is the second most common neurodegenerative disorder behind Alzheimer's disease. Surprisingly, its prevalence is increasing more than any other neurodegenerative condition, so this is something we're going to continue to see, possibly in increasing amounts. It is characterized by a destruction of dopaminergic neurons in the substantia nigra and pars compacta. Interestingly, it's not just a reduction in dopamine, you also get effects that impact upon other neurotransmitter systems, particularly noradrenaline, GABA, and serotonin. The hallmark of Parkinson's disease is the deposition of Lewy bodies or misfolded alpha-synuclein in the neurons, which leads them to die. The typical motor symptoms of Parkinson's disease that we're all familiar with, those tend not to manifest until approximately 70 to 80% of dopaminergic neurons have been destroyed. And the typical motor manifestations are bradykinesia, so slowness in movement, tremor, muscular rigidity, and postural instability. And as the disease progresses, those motor fluctuations and some non-motor symptoms, which we'll see later on, can have a significant impact on patients and leave them severely disabled. Now, there are many tools out there and there are many diagrams that try to make sense of how Parkinson's disease progresses. And this is one of my favorite images to use. It sort of breaks Parkinson's down into one of four different phases. So patients typically go through the diagnosis phase where they see a specialist, they get their diagnosis, shortly after which they may proceed into the maintenance phase. And the maintenance phase is characterized by a good response to medications. Patients tolerate their medications well, and their medications are highly efficacious for managing their motor symptoms. So patients generally retain a good quality of life. After ongoing neurodegeneration, patients will progress into the complex phase, where they need increasing amounts of dopaminergic medicines. They may start to poorly tolerate those medicines. You may get motor fluctuations where patients experience more episodes of off control, where they experience significant rigidity and bradykinesia. And again, non-motor symptoms start to manifest, things like autonomic dysfunction leading to falls and cognitive impairment. In the severe end stages of the disease, patients will enter that palliative phase where there is a reduced response to their medications, cognitive impairment and psychosis may occur, and life-limiting manifestations start to present themselves, such as dysphagia with recurrent aspiration pneumonias. I think one of the important things to take away from this slide is the error bars and variations that we can see in the progression of Parkinson's disease. For example, the maintenance phase, 5.9 years plus or minus another 5 years. This means on an individual patient basis, two patients can present and progress at very different rates in terms of their Parkinson's disease. So we need to understand and respect that heterogeneity. And this again is just another image that shows how Parkinson's disease progresses over time. Whilst those dopaminergic neurons are above that 30%, patients may not have motor symptoms, but they may develop some sort of pre-motor, non-motor symptoms, things like constipation, REM sleep behavior disorder. Once they drop below 30%, they enter that motor phase and things can progressively worsen over a small number of decades. Patients will develop autonomic dysfunction due to destruction of the autonomic nervous system. This can lead to things such as urinary symptoms, postural drops. Patients start to develop complex motor control issues where they need increasingly complex medicines. And as things like cognitive impairment start to manifest, patients may not tolerate their medicines as well as they did before, and they're at risk of consequences such as psychosis. Now, in terms of managing Parkinson's disease, we have a variety of different medicines available to us. And these typically are used to try and augment dopaminergic transmission in the brain, particularly in the substantia nigra. And we currently can't slow down that neurodegeneration in Parkinson's disease. There is no neuroprotective drugs. So we are simply using medicines to manage those motor symptoms symptomatically. And the mainstay of treatment for patients with Parkinson's disease tends to be levodopa. Levodopa, when delivered to the brain, is taken up by the neurons, converted to dopamine, and released to try and augment dopaminergic neurotransmission. The main challenge with levodopa is once you swallow it and it gets into your bowel and it gets into your peripheral circulation, endogenous enzymes start to break down levodopa. So we administer levodopa with dopa decarboxylase inhibitors, things such as carbidopa. That's why you'll see cocaryldopa and corbenyldopa, which help to protect levodopa when it goes through the bowel and the periphery, so more levodopa can be delivered to the brain. We also have other enzyme inhibitors that we can add in, things like catechol or methyltransferase inhibitors, again, to try and protect levodopa so more can be delivered to the brain. We can also augment dopaminergic neurotransmission centrally with other drugs. We can use dopamine agonists, which directly stimulate dopamine receptors, things like pramipexole, apomorphine, and rotigotine. We can also centrally try to prolong the lifespan of dopamine by giving things such as monoamine oxidase inhibitors, which reduce the degradation of dopamine, again, to try and prolong its action. When it comes to medications, things like levodopa tend to be the mainstay because levodopa is perhaps the most efficacious medicine for Parkinson's disease and the most well tolerated. Things like dopamine receptor agonists, such as rotigotine, tend to be tolerated better in early disease, but in later disease, when the brain becomes more vulnerable and there is extensive neurodegeneration and underlying cognitive impairment starts to manifest, patients may develop extreme side effects from these drugs, things like psychosis and hallucinations. So we find that medication regimes change throughout the disease course, and patients' ability to tolerate certain medicines may diminish as the disease progresses as well. In terms of levodopa, again, this is the backbone of many motor control medicines, medication regimes for patients with Parkinson's disease. And again, the response to levodopa changes over the course of the disease. In early disease, you still have some functioning presynaptic dopaminergic neurons. This means they can take the levodopa, convert it to dopamine, store it in vesicles, and release it in a controlled manner. Importantly, these dopaminergic neurons are sensitive to the negative feedback of dopamine, which means you get controlled, proportional dopaminergic neurotransmission. And you can see this in early disease. Patients tend to respond well to levodopa, with levodopa having a prolonged and sustained action. So in early disease, patients may only need levodopa 2 to 3 times a day. As the disease progresses and as the neurodegeneration worsens, you find that some of these presynaptic dopaminergic neurons will die. What then happens as a result is levodopa is converted to dopamine by other neurons, such as serotonin. And since serotonin is not responsive to the negative feedback of dopamine, you will not get a controlled release. You will essentially get a full dose dump and a quick activity, which sets off very quickly as well. And as disease progresses, the response to levodopa changes. You get a greater peak effect and a greater tail off. And that is because you've lost your ability to store and release it in a controlled fashion. So not only do patients change in their tolerability of medicines as the disease progresses, they change in their response to medications. And with levodopa, you find that the therapeutic window in which you want to maintain control changes over time with levodopa in Parkinson's disease. It essentially, the therapeutic window closes in on itself. Now, as those neurons die and as you get uncontrolled dopaminergic transmission, patients are at risk of peak effects from levodopa, which can manifest as dyskinesias, those uncontrolled involuntary movements. And again, as the disease progresses, you need higher doses of medicines to get a motor response. So you get this therapeutic window that not only raises in terms of the minimum effective dose, it reduces in terms of doses that will precipitate side effects. So in end stages and advanced stages of disease, patients typically have motor fluctuations where they may experience periods of increased movement. So there's dyskinesias and motor off phases where the serum levels or the effective levodopa dips and they're left with their motor impairment. So in the complex phase, we may also use things like device-assisted treatments to try and really stabilize those motor fluctuations and make sure patients get stable serum levels of drugs. And that can be achieved with things like continuous intestinal levodopa, where patients have a PEG tube fitted with a PEG extension, and essentially a small insulin pump-like device infuses levodopa into the small bowel continuously to give you stable serum levels to try and reduce those peak and trough effects. We can also do something similar with continuous apomorphine infusions, again, which is a small insulin pump-like device that infuses apomorphine continuously. We also have other options such as deep brain stimulation, where electrodes are surgically placed into the brain, and those provide electrical stimulation, the frequency of which are optimized to the patient and help reduce motor fluctuations as well. The difference is with these two therapies, so apomorphine and intestinal levodopa, these tend to replace the majority of the patient's oral medication regimes. So if we see these as palliative care specialists, particularly if patients are nil by mouth, or if they're approaching the end of their lives, we can typically continue them. When it comes to deep brain stimulation, patients typically remain on an oral dose of medications as well as receiving deep brain stimulation. So with these patients, if they're approaching the end of their lives or they're nil by mouth, we may have to continue the deep brain stimulation and also convert oral medicines to an alternative route of administration. Now, the main thing for today is I wanted to really address some of the challenges and issues we will encounter as palliative care specialists and the things we're often asked to help manage. And one of those issues is often swallowing issues. And I think swallowing issues are important because most patients with Parkinson's disease will die of an aspiration pneumonia, particularly if they have advanced disease. And this often results in acute admissions to hospital. So you find that over 50% of patients who die with their Parkinson's, die from their Parkinson's disease, die in hospital. So I think it's important that we can understand how to manipulate motor medication regimes so if patients do become nil by mouth, we can convert them to an alternative route of administration. And given the prognosis is often very difficult to predict in patients with Parkinson's disease, especially when they're at risk of acute illnesses, such as things like pneumonia, we're often parallel planning. Patients may surprise us and may improve, and as a result, we may need to convert them to alternative routes of administration whilst they're nil by mouth, but if they improve, we may need to convert them back to what they were previously on. Now, in terms of swallowing issues, I often get asked, do we need to continue dopaminergic medicines when patients are nil by mouth or they're dying? And although we don't fully know the correct way to continue motor medications because some of the evidence is in its infancy, we do know that from an expert opinion and from observational evidence, it seems very important that we continue dopaminergic medicines for motor control during periods of nil by mouth, even at the end of life. If you do abruptly stop motor control medicines, you can precipitate compromised motor control, rigidity, stiffness. Patients can't move, they may not be able to talk, they may not be able to swallow. This can lead to significant symptoms and significant distress. Additionally, if certain medicines, such as dopamine agonists, are rapidly stopped, patients can precipitate and have dopamine withdrawal syndrome, which is characterized by dopamine agonist withdrawal syndrome, which is characterized by anxiety, distress, and fear. And a rapid reduction in dopaminergic neurotransmission in the brain can also lead to something called Parkinsonism hyperpyrexia syndrome, which essentially is neuroleptic malignant syndrome and is potentially fatal in its own right if not managed correctly. And when we do manage patients with advanced disease, particularly those approaching the end of life, what are the trends? How do we typically manage patients who may be nil by mouth of their medicines? And when you look at the studies, there are clear trends. We seem to, in a lot of cases, 90% of cases, convert patients to transdermal reticulatine. It provides a very non-invasive way of continuing motor control for patients who are nil by mouth. In a small number of patients, we may continue their device-assisted treatments, particularly things like apomorphine infusions. For a small percentage of patients as well, we may continue to administer their dispersible medicines down enteral feeding tubes. And when you do look at these studies that do assess motor control at the end of life, you always find a small percentage of patients who haven't been given motor control during that end of life period. And those patients have disproportionately higher rates of pain, distress, and agitation, which takes us back to that first point that we should be continuing motor control in these patients. Now, if you encounter a patient who is nil by mouth, there are lots of different things to consider. Patients often have recurrent episodes of acute illness, and they usually experience frequent episodes of being nil by mouth. So there may already be a backup plan in place. We simply may just have to find that plan and put it into place. The other thing maybe to consider, where is my patient in their Parkinson's disease trajectory? Would something such as a new NG or PEG tube be appropriate and be compatible with where they are in their disease trajectory and with the patient's wishes? If we're thinking about using things like transdermal reticotine, which is a dopamine agonist, we've also got to consider what are the risks of neuropsychiatric reactions in my patient. If I have a patient who is elderly, who is frail, who has delirium or cognitive impairment, then dopamine agonists have the potential to precipitate and worsen neuropsychiatric reactions. If patients have pre-existing PEGs in place, maybe we can just use them. And if patients have device-assisted treatments in place, maybe we can just continue to use them as well. And what sometimes is the easiest option to do in patients who become nil by mouth, if they are unable to swallow solid dosage forms, but can still swallow dispersible preparations or liquid preparations, or they have a PEG tube in situ, then maybe we just need to convert their solid medication dosage forms to dispersible. And if somebody is on a solid dosage form regime of carbidopa, for example, you would just simply convert that to equivalent doses of dispersible preparations at the exact same time, which could be taken orally or via a PEG tube. In this example, somebody taking 125 dispersible on the morning to overcome early morning dyskinesias, overcome morning akinesia, that could just be given via the PEG tube at 7 a.m. Their 250 QDS, carbidopa, could just be given as 250 dispersible QDS at exactly the same times, and their 250 MR at night could also just be given as 250 dispersible at night at the exact same time. If you do this for somebody who can't swallow solid dosage forms or has a PEG tube in place, you just need to be aware that the kinetics of dispersible levodopa are not identical to the kinetics of levodopa tablets or capsules. Dispersible preparations will hit a higher peak more quickly, and they will hit a lower trough again more quickly. As a result of that, patients may experience fluctuations in their motor control. So it's often good practice when changing somebody to a dispersible regime to also add in PRN dispersible levodopa. So if they experience a sudden motor off, we can give them something to treat that. If you do have a patient who is on a very complicated oral regime, they're taking several doses of levodopa, they're on oral dopamine agonists, and they're taking things like monoamine oxidase inhibitors, and you're wondering how to convert that to be given as dispersible or crushed formulations for oral administration or via a PEG, your best course of action is to go to the parkinsonscalculator.com. And what this allows you to do is it allows you to plug in your patient's medication regime, the doses and times they're taking it, and it will give you a protocol of what to do to administer those medicines as dispersible or crushed dosage forms. And it gives you it as a PDF, so you can print it out and put it at the patient's bedside, or you can upload it to the patient's records. It's also quite clever in that it will tell you how to convert modified release oral preparations, such as oral dopamine agonists, to equivalent doses of immediate release preparations, and also how to change the dosing frequency to compensate for the fact that you're now giving immediate release rather than modified release. So quite a good tool to use. The thing we often do in patients who are nil by mouth, particularly in advanced stages of disease and those possibly approaching the end of their lives, is we convert to reticotine. And reticotine in patients with advanced Parkinson's disease is something that we can and should do, but we should embark upon that journey with caution. What we find is that advanced Parkinson's disease is associated with delirium, dementia, psychosis, frailty, and multimorbidities. And the risks of adverse effects from reticotine are much, much greater than those from levodopa. The risks of hallucinations, somnolence, delirium, confusion, and orthostatic hypotension all occur to higher degrees with dopamine agonists than they do with levodopa. So when we convert patients with advanced disease from levodopa to reticotine, we have to bear in mind that we're probably converting from levodopa, which is the most efficacious and well-tolerated drug, to a dopamine agonist, which is probably the least well-tolerated classes of drugs. So we need to do that with caution. The other thing to consider is then, how do we convert? And there are lots of different calculators out there that tell us how to convert from levodopa to reticotine. And when you look at the studies that assess reticotine prescribing at the end of life, you see the dosing varies widely. And I believe that's partly due to the fact that there are so many different calculators out there, we don't always know which one to use, and that leads to a lot of variability in which calculator we use and what dose of reticotine we prescribe. The main two calculators that can help you convert from oral motor control medicines to transdermal reticotine are the optimal calculator and the PD med calculator. And even those two calculators can give you very different responses. So here we have an example of a levodopa dosing regimes. Here is what the PD med calculator says is an equivalent dose of reticotine. And here is what the optimal calculator says is an equivalent dose of reticotine. So let's just take one of these as an example. If your patient is on 187.5 milligrams of corbenyl-dopa QDS, the PD med calculator would tell you that is equivalent to 4 milligrams of reticotine. If you use the optimal calculator, it would tell you that is equivalent to 14 milligrams of reticotine. And in brackets, if your patient is at risk of delirium or has dementia, you would pragmatically reduce that to 10 milligrams. So in complex frail patients, we have two different calculators, one telling you 4 milligrams and another telling you 10 milligrams. So what do we actually do? Well, we did a bit of a study where we looked at patients who had been admitted to hospital with idiopathic Parkinson's disease and died. We very much went through the patient's medical records, their clinic letters to confirm they had idiopathic Parkinson's disease. We also assessed for the presence of things like cognitive impairment, and we determined how long each patient had had their diagnosis for. And in most cases, patients had had Parkinson's disease for more than 10 years. So we felt this was an advanced group of patients with advanced Parkinson's disease. The majority of patients also died as a result of aspiration pneumonias, which is typical in patients with advanced Parkinson's disease. So we felt this population was representative of patients dying from advanced Parkinson's disease. And what we did is, when these patients were admitted, we looked at what medications they were taking for their motor control. We then used the PD med calculator, which is the one that gives you a conservative dose equivalence, and calculated what an equivalent dose of reticotine should have been according to that calculator. We then looked at what doses of reticotine patients were actually given. Approximately a third of patients were given a higher dose of reticotine, approximately a third were given an equivalent dose, and approximately a third were given a lower dose. We also wanted to see how potential end-of-life symptoms mapped to reticotine dosing as well. So we looked for the development of subsequent agitation, and that was determined by the use of subcut PRN benzodiazepines. It was also determined by the presence of agitation or distress being written in the patient's medical notes or their care of the dying patient documents. And we also looked for other symptoms. We were concerned that if patients were given lower doses of reticotine, that could worsen pain because of compromised motor control. We were also concerned that if we give lower doses of reticotine, then symptoms such as respiratory secretions may worsen, because again, if doses reduce and motor control worsens, maybe they can't swallow as well and they're more at risk of respiratory secretions. But the results were quite interesting. As you would expect, we found that patients given higher doses of reticotine experienced significantly more agitation and distress. What is interesting about the patient group giving higher doses of reticotine is they had the lowest amount of dementia and delirium, yet they still had the highest rates of agitation and distress due to more likely than not the increased doses of reticotine. We also found that subsequent pain after the initiation of reticotine did not differ between all three groups. So giving higher doses of reticotine was more likely to cause distress, and giving equivalent and lower doses of reticotine did not worsen pain. And the rates of distress between those taking equivalent and lower doses of reticotine was similar. What we did find that was quite interesting, which I can't explain, is that patients on lower doses of reticotine actually experienced less respiratory secretions. So this implies that we should be giving equivalent or lower doses of reticotine which are more likely to be better tolerated at the end of life without a detriment to things like pain, and lower doses may be more protective in terms of other symptoms such as respiratory secretions. And these trends have also been shown by some other studies. Here's a study by Hewer et al., and they again mapped symptom management at the end of life to reticotine dosing, and they found a positive association between reticotine dosing and total benzodiazepine use in the final 72 hours of life. So higher doses driving agitation. Like us, they also found no association between reticotine dosing and the use of analgesics, again implying that higher doses may cause agitation without improving symptom control such as pain, so lower doses may be better tolerated without a detriment to the patient's pain. Ibrahim et al. Also found similar trends. They found higher rates of delirium and hallucinations in patients given higher doses of reticotine. And what was quite important and quite interesting is they had this small subgroup of patients who were naive to dopamine agonists. And when this group of patients who were naive to dopamine agonists were started on reticotine, regardless of dose, they experienced disproportionately higher rates of agitation and distress. Again, that serves as a reminder that initiating these drugs in patients with advanced disease needs to be done cautiously because they are likely to be poorly tolerated. So what do we do in terms of managing reticotine in patients who lose their swallow? Well, this is taken from our trust guidance, and this was actually written by my wife, so I need to speak positively of it. But we find that when you want to convert somebody from their oral motor control medicines to reticotine, you need to consider the heterogeneity of the disease. So if you have a patient who is elderly, has potentially underlying cognitive impairment, or is at risk of delirium, which is typical in patients with advanced disease, you should be using the PD Med calculator to give you a conservative dose of reticotine. And in most cases, you should probably cap that dose of reticotine at 4 milligrams in 24 hours. If, however, you are seeing a patient who is younger, who is earlier in their Parkinson's disease trajectory, is in that honeymoon phase, for example, and probably would tolerate dopamine agonists quite well, and this may be a patient, for example, who has lost oral access due to nausea and vomiting as they're undergoing chemotherapy. In those patients, you can probably use the optimal calculator and give them more of an equivalent dose. But for patients who are potentially approaching the end of their lives with advanced disease, we need to go pragmatically with the PD Med calculator, and we probably need to start at around 4 milligrams. And once we start reticotine, we need to realize that that is just the start of the process. We tend to find that when you assess reticotine prescribing at the end of life, the dose doesn't really change that often. And the question is, are we assessing reticotine on a daily basis once we've initiated a patient on it? And we should be. And the UPDRS gives you a full guideline of how you assess Parkinson's disease, and it's a full holistic tool that is quite large. But what we do in patients who have started on reticotine, we've pragmatically taken more relevant elements from that assessment tool. And this is what we would typically do if a patient is initiated on reticotine at the end of life. On a daily basis, we would assess their rigidity, their tremor, we would assess their other symptoms, and we would assess for potential side effects of the reticotine, things such as hallucinations and psychosis. And we would use those findings to really optimize our dosing. If somebody seems to have poor motor control, they're rigid, they're tremulous, then maybe we might increase their reticotine by 2 milligrams every 24 to 48 hours. Whereas if somebody has started to hallucinate or they're becoming more agitated, we may reduce their reticotine by 2 milligrams every 24 to 48 hours. And the reason I say 24 to 48 hours is that is the time it takes for reticotine to achieve steady state. And that is another important consideration, because if you have somebody who is agitated and distressed and it appears to be dying, yes, we can reduce the reticotine, but it's going to take 1 to 2 days for that to fully take effect. So we possibly also need to consider other options in real time to manage the agitation and distress. And again, once we've converted to reticotine, we also have to be prepared to convert backwards. So remember, what we've said is prognostication is often hard in patients with Parkinson's disease, and some patients will improve and some patients will regain their swallow. And if that is the case, we should be converting back to their enteral medication regimes as soon as we can. And this is because things like levodopa carry a much smaller risk of adverse effects than rotigotine. And this isn't always possible. Some patients may remain on rotigotine until they die, and that is fine. But if we do get a window to convert back to oral meds, that might be the safest option. The other situation is we may start a rotigotine patch whilst the patient's waiting for the placement of an enteral feeding tube. And if that's the case, we then may convert from the rotigotine back to enteral medications, which can be given down the enteral feeding tube. And if you're converting from rotigotine back to oral medicines, you simply remove the rotigotine patch at the time you give the patient's first dose of levodopa. It's as simple as that. Now, when it comes to managing symptoms in patients with Parkinson's disease, patients with Parkinson's disease experience a number of symptoms throughout their disease course. And in most cases, patients experience more than 3 or more symptoms concurrently. And the symptom burden of Parkinson's disease has been estimated to be equivalent to those experiencing or living with advanced malignancy. And symptoms that can occur at the end of life in patients with Parkinson's disease are the typical symptoms we would expect. There's nothing surprising there. The symptoms that we're used to managing. So what I want to do now is have a look at some of the more pertinent non-motor symptoms that we are typically asked to be involved with as palliative care specialists, and how we might manage those symptoms, not only if patients can take all medications orally, but what we might do if patients are dying and we have no oral route of access. Now, one of the symptoms that I often get asked about is nausea and vomiting, because with nausea and vomiting in patients with Parkinson's disease, you often feel like you're between a rock and a hard place. And this is because centrally, patients with Parkinson's disease have a destruction of their dopaminergic neurons. Their dopaminergic reserve is reduced. And because of that, we want to avoid medications which can antagonize and block central dopamine. So some of our usual antiemetics, things like metoclopramide and antipsychotics, are off the table. If we use these drugs, we may further worsen the patient's Parkinsonism, worsen their motor control, precipitate things such as dysphagia and aspiration. So medicines that we typically need to avoid. And again, starting antipsychotics, particularly those that have a high tendency to block dopamine, may also risk neuroleptic malignant syndrome in these patients. So we have a much smaller array of antiemetics that we can use in patients with Parkinson's disease. And even the ones we can use are helpful, but again, they're not perfect. So domperidone is often one of the first-line antiemetics that we use in patients with Parkinson's disease. It is a dopamine agonist, so works in the bowel and at the chemoreceptor trigger zone. But importantly, its penetration across the blood-brain barrier is negligible, so it tends not to worsen or exacerbate Parkinsonism. The major issue with domperidone is it's only available as oral dosage forms. So if your patient is vomiting and they're probably not going to absorb oral meds, or they're nil by mouth, which is common in patients with Parkinson's disease, then we might not be able to administer domperidone. Suppositories are available as an unlicensed import, and that may be a possible option if you can get your hands on them. Cyclizine is also an option in patients with Parkinson's disease. You'll find many resources actually query whether we should be using cyclizine in patients with Parkinsonism, because there are reports of it worsening and precipitating movement disorders. When you look at the MHRA yellow card data, which has been compiled over many decades for cyclizine, you see that the risk for cyclizine worsening Parkinsonism is quite rare. And as a result, it can be used in patients with Parkinson's disease. The theory is that the dopaminergic and cholinergic systems are finely balanced, and if you add a centrally acting anticholinergic such as cyclizine, you can tip the balance and worsen motor control. But we don't typically see that in practice, so cyclizine can be used. Interesting with cyclizine, when we do use it from our practice in patients with advanced Parkinson's disease, particularly if there's cognitive impairment, we use smaller doses, such as 25 milligrams subcut PRN TDS, and have found in many cases that has been well tolerated and highly effective. Many resources also highlight hyoscine hydrobromide as a centrally acting antiemetic, which is appropriate for use in patients with Parkinson's disease. Now, although many resources say that, this is not something that we typically use very often. It has a significant anticholinergic burden. And if you consider patients with Parkinson's disease tend to be frail with multi-comorbidities, potentially have underlying cognitive impairment, something as anticholinergic as hyoscine can precipitate delirium and worsen agitation and distress. So something that is probably safe from a Parkinsonism perspective, because it's not going to worsen motor control, but may not be well tolerated due to other factors. Ondansetron is also listed as a safe antiemetic to use in patients with Parkinson's disease, and it can be given orally and subcut, and it doesn't lead to a deterioration in motor control. The one thing I sometimes question about ondansetron is in other patient groups outside of Parkinson's disease, outside of radio and chemotherapy, we wouldn't use it traditionally as a first line in a palliative patient. So I sometimes wonder whether it will be efficacious in patients with Parkinson's disease or not. So we do have some options we can use: domperidone, cyclizine, and ondansetron. But I often get asked, if I've tried those therapies and they haven't worked, can we use antipsychotics? So when people have tried domperidone, cyclizine, and ondansetron, and they've found that the nausea and vomiting has remained refractory to those agents, I often get asked, can we use an antipsychotic agent? And again, that is a decision that needs to be made very cautiously given the risk of deteriorating the patient's motor control. But for me, there was a study by DeFabio et al., and this wasn't in patients with Parkinson's disease. It was in patients receiving antipsychotics for schizophrenia and bipolar disorder. And all of the patients in this study developed drug-induced Parkinsonism. And when they tried to de-escalate the patient's antipsychotic, they found that their psychosis promptly returned. So what they did is they continued the offending antipsychotic and added in a small dose of retigotine, which is very brave in a patient with psychosis, giving them retigotine, which can cause and drive psychosis. Interestingly, in all patients bar one, they found that the patient's psychosis remained controlled and their motor symptoms improved with retigotine. And what the authors concluded is that retigotine is very broad spectrum in its action. It acts as an agonist at D2 and D3 receptors. It also acts at 5-HT1A receptors, which lead to downstream dopamine release. So they concluded that retigotine, due to its broad action, can navigate around antipsychotics, and that's why it remained effective. And what we have also done in several cases, in patients with refractory nausea and vomiting, we have also used cautious doses of levomepromazine. And we found that small, cautious doses of levomepromazine have been well tolerated and efficacious in patients with refractory nausea and vomiting. And when you look at the pharmacokinetics of levomepromazine and retigotine, they are quite complementary. Retigotine has a much higher lipophilicity than levomepromazine, so will attain higher serum levels. Retigotine has a much greater binding affinity to the dopamine receptors in the brain, so it'll occupy more of those receptors. And once bound to a receptor, retigotine dissociates away slowly, meaning that retigotine overall will occupy and maintain a greater receptor density than levomepromazine. And this may leave levomepromazine free to modulate nausea and vomiting through other receptors and through other actions, possibly at the chemoreceptor trigger zone. So to answer that question, I typically suggest that we try safe antiemetics first: domperidone, cyclizine, ondansetron. If they are not working and patients have refractory nausea and vomiting, in those on retigotine, maybe small, cautious doses of antipsychotics may be helpful. And there are reports out there of nausea and vomiting being helped by things like quetiapine and small doses of levomepromazine. But again, we need to be conscious of the potential risks and the potential deterioration in motor control. Another symptom that occurs quite commonly in patients with Parkinson's disease is pain. And pain is present in over 80% of patients with Parkinson's disease, and they tend to have multiple pains. Some of those pains may be attributable to the Parkinson's disease itself, and some of those pains may be attributable to other pathology, such as osteoarthritis, which is what you would expect in an advanced and aging population. Interestingly, patients with Parkinson's disease can also develop hyperalgesia. Those descending pathways that typically inhibit pain signaling and help regulate pain, the sensation and perception of pain, can be diminished in patients with Parkinson's disease as a result of the neurodegeneration. So patients with Parkinson's disease can develop these sort of centralized, nociplastic pains that don't tend to correlate to injury or any known pathology. And I'm not here to teach palliative care specialists how to holistically manage pain. That is what we are exceptionally good at. But when it comes to managing pain in patients with Parkinson's disease, I think it's important to consider an additional 2 elements to our pain assessment. And one of the things to do is to try and ascertain if the patient is experiencing any PD-related pains, such as muscular rigidity, cramping, dystonias, and to have an awareness of those pains that may be exacerbated by Parkinson's disease, such as posture abnormalities due to that rigidity and akinesia, pressure damage because patients aren't able to move and change position. Arthritic pains may be worse because of Parkinson's disease, because joints are under greater stress and strain and patients can't actively move or change position in those joints. And if we do have pains that are secondary to PD or worsened by PD, it's important to map the patient's pain on top of their motor control medicines. And sometimes what you find is that pains may be worse due to peak effects of medications. For example, peak effect of levodopa. If their pain's worse 60 minutes after taking levodopa, could that be a dystonia secondary to peak effect of levodopa? If their pains are worse maybe 3 to 4 hours after taking levodopa, does that correlate with the dip, that trough serum level, and could they be in the off motor phase? And if we find that pains do map with their motor control, a good way to manage that patient's pain may be to optimize their motor medicines, speak with their specialist teams, fractionate their levodopa dosing to try and maintain them in the on phase more consistently, which may help with their pain. And again, for things like PD related pains, there are lots of non-pharmacological options that can be helpful. Physio can be very helpful. Acupuncture, particularly for myofascial pain, can be helpful. And again, if patients are experiencing sort of dystonias that are quite focal, Botox to single muscular groups can also be very advantageous in terms of pain control. And failing all of that, we do have our usual arsenal of analgesic medicines which we can use. In terms of managing pain at the end of life, I think one consideration to have is you probably changed the patient from their oral medications to something non-oral, such as a transdermal reticotine patch. It's important in that point just to consider whether a deterioration in pain may be secondary to poor motor control, do an assessment of tone, tremor, rigidity, and if those are increased, maybe increasing the reticotine patch could be helpful for the patient's pain management. We also do have other options at the end of life. Nursing cares can be very good for pain control, particularly in patients who are akinetic and can't reposition themselves. Physio, in terms of passive movements and stretches, can also be very helpful. For patients who are developing contractures, splinting may be helpful. And of course, if there is excess rigidity, things like midazolam may be helpful, and even clonidine may be helpful, but more about that later. And again, we have our usual arsenal of medicines to manage pain as well, things like subcut opioids. The one thing to say about pain in patients with Parkinson's disease is they experience a significant amount of pain, and the analgesic use often shows that pain is undertreated. And patients at the end of life are often confused, delirious, or not able to communicate. So we probably need to be using non-verbal pain assessments as standards in these patients at the end of life and in patients with advanced disease. The other non-motor symptoms that patients can experience are psychosis, particularly in the form of hallucinations and delusions. And psychosis is perhaps the most distressing non-motor symptom that patients can develop and puts a significant strain on their carers and their family. And psychosis and delusions can occur in over 60% of patients with Parkinson's disease, and it can be due to the Parkinson's disorder itself. In advanced disease, we start to get Lewy body deposits in that cortical tissue. Delusions and hallucinations and psychosis may also be due to age-related changes. It could signal cognitive impairment. It may have been precipitated by things such as medications, and those dopaminergic medicines that patients are taking, they may have tolerated them once upon a time, but now that there is ongoing neurodegeneration, their brain has become more vulnerable to the side effects of these medicines. These motor medicines that were once helping the patient may now be contributing to and driving psychosis. And again, we're also talking about a very frail demographic of patients who are also prone to acute illnesses such as infection, dehydration, and all of these things may precipitate and cause psychosis as well. So if we do have a patient with Parkinson's disease who develops psychosis, we need to do what we're good at. We need to cast that broad net, and we need to look for potentially acute reversible causes. Things like pain, constipation, which is common in Parkinson's disease, infection, dehydration. If there are no acute reversible causes, we then need to consider how we're going to manage the patient's psychosis. And if the patient is hallucinating, is not disturbed by those hallucinations and regains insight, maybe we just need to monitor the situation. But if we're finding that the patient has developed very severe and distressing psychosis and delusions, then possibly in the absence of acute reversible causes, we may need to de-escalate some of their motor control medicines, which may be driving dopamine and may be contributing to the psychosis. Now, in terms of managing psychosis in the absence of reversible causes, one option is to consider a staggered withdrawal of the patient's anti-Parkinsonian medications to try and reduce that dopaminergic drive, which may be contributing to the psychosis. And when we do that, we typically stop the least efficacious agents first and try to preserve the more efficacious agents. So we typically stop things like anticholinergics and amantadine first. That doesn't work, we may de-escalate dopamine agonists, then monoamine oxidase inhibitors, then COMT inhibitors, and if absolutely necessary, we may even have to dose reduce levodopa. If you get to a point where symptoms aren't improved by a de-escalation of anti-Parkinsonian medications, or a patient cannot tolerate a de-escalation of their anti-Parkinsonian medications, we may have to consider the use of an antipsychotic agent, such as clozapine, quetiapine, or if you're in the United States of America, pimavanserin. An important side note is just to consider that cholinesterase inhibitors, particularly in patients with dementia, can be helpful. And rivastigmine, which is available as oral preparations and as transdermal patches, has been shown to help with hallucinations associated with PD dementia. In terms of antipsychotics, the gold standard antipsychotic in patients with Parkinson's disease is clozapine. It is perhaps the most efficacious and well tolerated. It doesn't lead to a deterioration of motor control because its tendency to block central dopamine is so low, but it's not often accessible for patients with advanced Parkinson's disease. Many services are inaccessible to these patients, and when you look at clozapine and the risk of agranulocytosis secondary to the drug, there is extensive biochemical monitoring that needs to be done as well, and that often prohibits the drug's use. So although things like clozapine is the gold standard antipsychotic to use in patients with Parkinson's disease, we often end up using quetiapine because it's a much more accessible drug. And from observational studies, at least, quetiapine seems effective. Observational studies have shown that quetiapine for psychosis and Parkinson's disease can be effective in up to 80% of cases and have postulated that it is almost equivalent to clozapine. When you look at the placebo-controlled trials, you get a different story. There have been 5 placebo-controlled trials, only one of which showed that quetiapine was effective. So most experts and most resources consider quetiapine to be probably effective for the management of Parkinson's psychosis, but we tend to use it more times than not just because it is much more accessible than clozapine. It is a sedative drug because it has sedative action through its antihistaminergic effects, and that can be helpful for patients who have sundowning. But remember, patients with Parkinson's disease often experience profound fatigue, and dopaminergic medicines can drive somnolence. So they can be somnolent from their motor control medicines, and adding in antipsychotics, which is sedative, can also worsen that. Due to autonomic dysfunction, again, patients with Parkinson's disease are at risk of postural hypertension and falls, and quetiapine can also block alpha-adrenergic receptors and worsen postural drops and falls. Its tendency to block central dopamine is very, very weak, and we find from the trials at least that quetiapine doesn't lead to a deterioration in motor control. So from that perspective, at least, it is quite safe. And interestingly, quetiapine may not work as an antipsychotic by blocking dopamine receptors in patients with Parkinson's disease. It may work by blocking serotonin. And that leads us on to pimavanserin. Pimavanserin is not currently licensed in the UK or in Europe, but it is licensed in America. And it is actually licensed for the management of psychosis in patients with Parkinson's disease. And it is the first ever licensed antipsychotic that does not act on central dopamine. Pimavanserin is purely a 5-HT2A and 5-HT2C antagonist. There's some speculation that it may be an inverse agonist, but for the time being, we'll consider it an antagonist. And that is quite interesting. This is an antipsychotic that is efficacious and does not work on central dopamine. And we know that serotonin is involved in the onset and manifestation of things like hallucinations, because that is how things like LSD and psilocybin work. And what can happen in Parkinson's disease is you not only get a reduction in dopaminergic neurons, you can get a reduction in serotonergic neurons. And to compensate for this, some brain regions overexpress serotonin receptors. And by doing that, they actually become hypersensitive to the effects of serotonin. And this is part of the hypothesis of why we believe serotonin is important and is a factor in the development of psychosis in patients with Parkinson's disease, and why drugs that purely antagonize serotonin have been shown to be efficacious. And that is quite interesting. So now, in terms of managing these neuropsychiatric reactions at the end of life, it may be difficult. But again, it's about casting that wide net and seeing if there are any reversible causes, constipation, fetal impaction, and urinary retention that we may be able to address. Again, if there are no acute reversible causes, there may be a trade-off between motor control and the psychosis and distress, and we may have to de-escalate things like reticketing and reduce the dose. We may then also need to use alternative agents to try and help with that rigidity, and also to try and help through their calming action. So things like benzodiazepines may be helpful. And if all else fails and de-escalations of motor control and benzodiazepines aren't having a net positive effect, we may need to consider cautious and pragmatic doses of things like antipsychotics, or even clonidine, which we'll see more about on the next slide. So clonidine is an alpha-2 agonist, and what it can do is it can have a very contradictory action depending on whether circuitry in the brain is overactive or underactive. In overactive circuits, it can bind to the autoreceptors presynaptically, which elicit a negative feedback response to switch off neurotransmitter release. So in overactive circuits, which may be contributing to psychosis, agitation, distress, and hallucinations, it can potentially calm down those circuits. In underactive circuits, such as those descending pathways, it can act as a postsynaptic agonist to increase neurotransmission. So it has the potential to decrease those overactive effects and increase those underactive effects. And there was a bit of a summary and a bit of a study from Paul Howard and John Curtin, who looked at the use of clonidine for patients with refractory symptoms at the end of life. And there was a subset of patients in this study who had Parkinson's disease, and they used clonidine for the management of things like rigidity, agitation and distress, and pain. And they found that in approximately 50% of patients, there was a complete resolution of their symptoms, whilst in the other set of patients, the other approximate 50%, there was a partial response. So there seems to be at least that clonidine may have a potential place in the management of symptoms at the end of life in patients with Parkinson's disease, and it may be quite a favourable drug as it doesn't antagonise or block central dopamine. So in terms of some final thoughts from me, I think it's just important to recognise that Parkinson's disease is a very heterogeneous condition, and it's heterogeneous in terms of its prognosis, that patients may progress at different rates, and that we are often parallel planning when patients are acutely unwell. It's also heterogeneous in terms of how patients may respond to their medications. Their motor control medication regimes change over time, and the way they respond to and tolerate those medicines also changes over time. A deterioration in swallow and patients becoming ill by mouth is often a frequent occurrence in advanced and late stage disease. So we need to be aware of how to manipulate motor control medication regimes to ensure they are continued safely during those periods of ill by mouth. Pain and neuropsychiatric reactions are common at the end of life, And in terms of managing symptoms, we often need to pragmatically balance motor control against the symptom and the use of symptomatic medicines to try and improve and lessen the burden of those symptoms. And we need to, in first cases, try to avoid the use of medicines which may antagonize and worsen dopaminergic neurotransmission, because they could lead to a deterioration in the patient's motor control. And if we're not winning with medicines that aren't antagonists of dopamine, we may need to cautiously and pragmatically consider small doses of antipsychotics, but being fully aware of the risks that they could lead to a motor deterioration. And that is the end of the session. And thank you very much for inviting me to be here. It's been a privilege, and thank you. I hope you enjoyed it, and I hope it was helpful.
Jonathan, for a superb lecture. I've taken away so many things, so many tips. And in particular, I loved your description of what happens to the neurons and the substantia nigra over time. That's just a superb explanation. That will stick in my head forever. Thank you. A couple of questions arising from your talk. And the first is thinking in order through the talk. You mentioned about the intestinal levodopa gel and the fact that people may be on apomorphine infusions. A little easier if you're in a hospital and that there's likely to be neurology reg on call. If you're in a hospice, I think your advice was to continue the infusions until you've spoken to neurology. I'm just thinking, how practical is this for most of us in a hospice setting?
Interestingly, I had a slide on this, which ended up on the cutting room floor, but it's at the back end of the presentation, so it can certainly be in the handouts. When it comes to the intestinal gel and apomorphine, we don't often see them that often at the end of life. So the intestinal gel, because of the surgery and the peg that needs to be fitted, many patients don't opt for it. And apomorphine tends to have a lifespan in patients with Parkinson's disease, that they may be on it for a period. And then because it's a dopamine agonist, they may start to poorly tolerate it. It may contribute to the psychosis. And then patients may end up back on a levodopa regime. So we see it quite infrequently. In terms of continuing them, I'll make sure that slide is part of the handouts, but I've put in there's some contact numbers. So what you can do is you can speak to the patient specialist team, but there is also, with both devices, there is 24-hour support available through the manufacturers as well. So they can tell you how to manage these devices if need be. It's also important that you work with the patient and their carers or their family who's managing this device, and whether that can continue, whether we need to possibly pick that up. And there are lots of ancillaries that need to go with the devices, things like the drug cassettes and the lines, and those usually get delivered to the patient's homes as part of home care. So it's about being aware of what we need and how we get that, and make sure we have arrangements that actually, if those are going to the patient's home, can somebody bring them in for us to use so we can continue these drugs during that end of life period. And again, if we need emergency supplies, there are contact numbers out there to get those from people like the manufacturers. The backup plan, which again is important to know, is that anybody on intestinal gel or anybody on apomorphine should have an emergency backup plan in place that has been agreed with their neurologist specialist. Because even though they're on these devices, there is a risk that they can break, they can fault, they can be dislodged. So most patients do have an emergency backup plan in place to implement if there is a problem with their device. So again, if they're dying in hospices, us knowing what that plan is and knowing what to implement if there is an issue with the device can also be very helpful.
Thank you, Jonathan. That's extremely helpful. Thank you. And I think the unexpected happens. So I guess these guys might present to emergency care, but on occasion they may choose to come into hospice care. Thank you. That's really helpful. Our trust locally uses the optimal calculator. So in our review of a year's worth of patients who either had Parkinson's disease as they were dying, or indeed were dying of Parkinson's disease, we found that actually there was a significant, as you did, proportion of people with agitation, but that we were so bad at checking for that and measuring it. So a couple of questions arising from that portion of your talk. The first is a comment, which is brilliant to see the new papers emerging. I think your paper that you did with your wife and Mark is a superb paper, and I recommend it to everybody, and we'll put it in the resources as one of the references. But it's great to see other papers arriving to support your work. I wondered whether you would be happy to share your trust guidance that your wife developed, all of us knowing that when we lift and shifted out of your trust, we're doing that at our own risk, and we may not be staying up to date. And secondly, for me, really importantly, the observation chart you have, because what we found was that people were good at assessing for pain, but forgot about all the other effects that might have been caused by the reticotine patches. So I just wondered whether you were happy to share those resources. Thank you.
And can I just, in terms of the reticotine effects, I forgot to mention that reticotine, being dopaminergic in its action, can also drive a lot of nausea and vomiting. So one thing with nausea and vomiting is just to consider whether there's been a recent change to reticotine, and a dose optimization might be helpful there as well.
Absolutely, Mark. Thank you for mentioning that. And of course, I think we'll spot the vomiting, won't we? But nausea is incredibly difficult to assess in this patient group.
So that's the other thing, that the data says that nausea and vomiting occurs very infrequently in patients with Parkinson's disease. But again, like you say, it's that non-verbal assessment of whether somebody's nauseated. It's very poor. What we did find, which was quite interesting, is the patients seem to have a higher proportion of fever at the end of life, potentially 1 in 4 patients. And for things like vomiting, which occur in maybe a small number, 2-3% of people, we seem to plan ahead for nausea and vomiting, but they're much more likely to get fever. And the question is, should we be planning ahead for that with somebody with Parkinson's disease as well, usually because they die of an aspiration pneumonia?
So it's infections driving that.
Yes.
Yeah, absolutely. Thank you. And of course, I suppose patients may have retained a response to infection that we mightn't be used to seeing in patients with cancer. Yeah, super. Thank you, Jonathan.
And again, if a patient does get that fever, it's just about checking their tone and everything, because that fever could be a sign of sort of Parkinsonism hyperpyrexia syndrome, essentially a neuroleptic malignant syndrome, which might need increases in dopaminergic medicines and benzodiazepines. So it's again just checking that it's not linking to a deterioration in motor control. If you've got a deterioration in motor control and fever, I'd be concerned that it could be that Parkinsonism hyperpyrexia syndrome.
Absolutely. Thank you so much. And leading on from that question, you mentioned a tool, a non-verbal assessment tool in patients. Is there anything that you favor in your trust and in your practice?
So I'm not sure it's valid. I don't know if it's validated for patients with Parkinson's disease, but we tend to use the Abbey Pain Score, and that was more of a pragmatic decision that our sort of dementia and delirium team, in terms of managing pain in patients who are confused and delirious, have really used that assessment and really rolled it out across our trust. So historically, people have had a good understanding of that tool. So we've pragmatically continued with that because that is what people are familiar with. And we didn't want to introduce something new and create more confusion. We thought if they're doing this reasonably well, we'll continue with that.
Absolutely. Thank you. That's really helpful, Jonathan. Thank you so much. And I also learned, in terms of thinking about the pain and the dopamine, it's a new tip to me to think about pain at the start of the dopamine dose and at the end. Thank you. That makes complete sense, but was new to me. Can I move on to talking about community and care, and as patients may be being discharged for care at home at the end of life, and they're in the last days of life, is it your practice in the trust to send people home with reticotine patches and to alert the community Parkinson's disease nurses as well too? What's your approach?
I don't think we've got any Parkinson's disease nurses in community, but we certainly do. As part of our emergency healthcare planning, we would typically write an emergency healthcare plan including non-verbal advice. And with our interactions with the patient and family, we would often write a plan in conjunction with them. So sometimes it's a case of the family are happy to move to reticotine if the patient has maybe missed 1 or 2 doses. But again, it's about them sometimes getting that medical review just to see if it's a reversible deterioration in swallow, because if it was something like oral thrush, which is readily treatable, we wouldn't want to miss that. But yeah, it's just that we often put a plan in the emergency healthcare plan for the patients and their family to follow and give them that backup issue. And that's the other thing when you're thinking about reticketing at the end of life. For many patients, they've had recurrent episodes of being unwell and going ill being ill by mouth for periods of time. And it's what was done during those periods. And sometimes that can give you a steer as to how well they tolerate reticketing and what doses they've had before. And that can be very useful when thinking about an emergency healthcare plan for somebody at the end of life.
A great thought, actually. That's so logical, Jonathan. Absolutely. What we found locally, so that there will be varying practices across the UK, and indeed people will be joining us for this course who will be working overseas. So there'll be varying practice and appreciating that. So we do have a fabulous community Parkinson's disease team here locally in Oxfordshire. So I'm used to that, I think. And their advice to us would be to always alert them if a patient is going home for care at the end of life at home, because they will pick up and they will help support the use of reticketing and watch out for all the adverse effects, as you've mentioned to us. And also they will also support transition back to oral medications if the patient unexpectedly starts to improve again. What we found locally, Jonathan, is extreme difficulty in getting reticketing patches out of hours. And sod's law, there's yet another bank holiday weekend around the corner for those of us in the UK, but we've started sending people home with 3 or 4 patches. It's not ideal, but we recognize it is often difficult to get a medical review. And at least if people are phoning into our hub, we do have some medications in the house at our fingertips. So I guess varying practice around the country. Thank you. May I move on to my last question, which is thinking about the use of levomepromazine. And I guess on occasion, my clinical experience has been that agitation doesn't seem to be settling with benzodiazepines, etc., and you've thought about all other causes. I'm just interested to know, when you say low dose levomepromazine, what dose as a PRN would you be thinking about? And indeed, what dose might you be thinking about if you wanted to use levomepromazine in a continuous subcutaneous infusion?
I suppose it's really difficult because it's really guided by that individual patient. So when we've used it, we've sometimes used as little as 2.5, possibly going from 3.125 to 6.25. And given that it's a long-acting drug, I think sometimes we don't necessarily feel we have to commit to a background dose straight away, and can probably go repeatedly and cautiously with top-up doses, knowing that if we reach that point where we control the symptom, at least the drug's going to be in the patient's system for a while, and we can take stock over a day or two of how much they've had, and then use that to sort of guide what we need to put in that infusion pump. But it can be very, very variable, and in most cases we found that very small doses have been tolerated and have actually been quite efficacious. So we would still start quite low, possibly 2.5 or 3.125, going to 6.25 PRNs if needed, and just letting those PRNs run for maybe 24 hours, see what's needed, and then make a decision from that point on.
Superb. Thank you. That's very valuable to remind us of that. And of course, if you reduce the reticketing patch in that period of time too, you should begin to see the levels dropping 24 to 48 hours. I guess. So
again, like you say, you might just need PRNs to cover, and as that reticketing washes out slowly, then the situation might have been essentially resolved with PRNs for a small period of time, and then the patient potentially needs less.
Lovely. Jonathan, thank you for a superb talk, and thank you to your wife for developing further resources to support our care. So thank you very much.
Thank you. Thank you for asking me to come.
It's been a superb lecture. I think there's lots for us to look up, to read, new papers to find, and to think about how to improve our practice in this area of care. Thank you, Jonathan.
Thank you very much.